Susan, please go ahead and give us your story.
Go forth and do. Well, thank you so much. It's really my pleasure to be here, and I hope everyone can hear me okay. Dr. Suter has been such a gracious man over the years, has provided us with supervision for many years, and I've learned so much from him. I'm grateful to Dr. Suter, Dr. Grant Bright, who actually brought neurofeedback to us initially at the Atlanta Healing Center, Dr. David Cantor for his great help and consultation, Jeff Reich, who has also worked with us, a number of other folks, too numerous to mention, but very grateful because truly I have to tell you that as a physician and as a psychiatrist, I'm embarrassed to say that it never really occurred to me to look at the organ I was treating. And I know some of you are out there probably laughing. I would laugh too if it wasn't so sad. The use of QEEGs and neurofeedback has changed my practice, has changed the lives of my patients, and I think has really improved their recovery and their opportunity to live a life free of drugs and alcohol. So here are my, well, maybe here are my, there we go. Now I'm moving too fast. Here are some of my disclosures. If anybody has any questions, let me know. I do want to spend just a moment of your time. I feel like I need to make sure that everyone is on the same page when we talk about what addiction is and what it isn't. I am not a huge fan, for a number of reasons, of the DSM-5. And so I prefer to use the American Society of Addiction Medicine's definition of addiction. It talks about addiction as being a primary illness, not secondary to someone's traumatic events, although that certainly does impact not only their course of treatment, but their success and has to be part of their treatment program. But it is a primary brain disease. It is a genetically inherited childhood brain disease, and it is a chronic illness that requires treatment as a chronic illness. To think that someone can go to a 28-day program and get through that and go forth and be fine is a huge mistake. And the 28-day myth is an actuarial calculation that the insurance company made based on the number of covered lives, the number of patients that they figure have the disease of addiction, and the small percentage of those that are going to go and seek treatment. It has nothing to do with the progression of the disease or the return of the diseased brain back to a more normal function. So we have to look at this as a chronic disease. It involves 3 different pathways in the brain. Most of us are very familiar with the reward pathway and the idea of dopamine, but it also involves the motivation pathway and the memory network and related circuitries. So when we look at the reward pathway, that's sort of what brings you to the dance, the nucleus accumbens and the ventral tegmental area. These are the 2 areas of the brain that release dopamine to about 30 different groups of chemicals. Out of all of the millions of molecules in the world, only about 30 things, including sugar, release dopamine in these 2 areas. That is what we need to see in order to define a behavior or a substance as being addictive. We have to see the release of the dopamine in this reward center. Now, that's what gets the person interested. The way their brain responds to drugs and alcohol is different than the way drugs and alcohol affect someone who does not have this disease. So that is the first step. They receive a great reward. They are much more interested, and the feedback loop that those of us who don't have the disease of addiction experience all the time, which shuts down the release of dopamine when we've had enough sex, drugs, rock and roll. They are missing that. So they do not get the feedback loop that they've had enough. A little is great, more is better. There is never enough. But that part of the system and the cycle of depression is really quite short-lived, unfortunately. And when we see people actually becoming affected by their drugs of their dopamine releasers of choice, getting into trouble, having consequences, generally the high is no longer really a part of it. It is involving the salience network, the memory and learning center, as well as the prefrontal cortex, which goes offline when any of us, whether we have the disease of addiction or not, when any of us has consumed enough alcohol, for example, our prefrontal cortex goes offline, and with it goes our good judgment and our ability to make good choices like don't drive while you're drinking. So these are the primary networks that perpetuate and continue the disease. The triggers that we talk about when folks are active in their disease or trying to get into early recovery are often involving the motivation and the learning center of the brain. So it's dysfunction in these circuits that lead to very characteristic biological, psychological, social, and spiritual manifestations. And this is a really important part, I think, of describing the disease. When you are under the influence of a drug, or when you are in detox or coming off of a drug, you are going to have very specific, drug-specific symptoms that are readily identifiable. There are also psychological changes that occur for folks, and the social changes are very impactful. We often talk about the disease of addiction being a disease that thrives in isolation. And we do see this. People become more and more isolated and withdrawn. They begin to not trust people who love them and care about them, and trust people who are really not trustworthy. And you see this pattern. The spiritual manifestations often makes people squirm in their seat a little bit when I talk about this. When I'm explaining this to folks, I'm talking about a sense of self-worth, a sense of being accepted, regardless of whether we feel like we are worthy of that acceptance and unconditional love, and really the feeling of hope. Most of our patients have lost those things. They may have had them at one time in their life, but as they've gotten more and more involved with their disease of addiction, they are less likely to have these kinds of connections. And it is through recovery of these connections as well that's very important in getting them back on their road to recovery. We see the individual pathologically pursuing a reward or a substance that can relieve the symptoms, or a similar substance or behavior. So a short definition of addiction is continued use of a substance or behavior in spite of consequences. Often patients will say, I have no idea why I'm using, I don't even like this, I don't want to do it, but the compulsion to continue to use is so powerful that they have difficulty stopping without some kind of formal intervention. So this may look like an inability to stay stopped. People who are binge type users, whether that's drugs, whether that's alcohol, it's a little bit more difficult for them to understand the difficulty and the diagnosis, because they say, I go to work all week, I just drink or use on the weekends. The difficulty is that when consequences begin to mount for that person, most people will say, you know what, a DUI, not doing me any good. I'm not going to do this anymore. And they're able to walk away. People who have the disease of addiction may stop for a time. Consequences may slow them down or stop them, but they have a very difficult time staying stopped in spite of promises made, in spite of knowledge about this is not going to end well for me. They have this difficulty in staying stopped. They have trouble in controlling their behavior, both with regards to use and also when they're under the influence. They have something called a craving, which is this obsession, continued thoughts. Often it can even be a physiological desire to go and engage in the behavior or use of drugs. They have well, as one of my patients who's actually a psychiatrist, and we make the worst patients, by the way, but a psychiatrist described this as a delusional disorder. And he talked about the idea that there is a real lack of insight on the part of the person who's active in their disease on how their problems are affecting themselves and others. So they will see this bottle, whether it's alcohol or pills or whatever, this bottle is the solution to how I cope with my boss who drives me nuts, my wife who's always nagging at me, my neighbor who's always yelling, and the policeman who just arrested me. So that is that person's coping mechanism, or how they define it. On the other hand, to the rest of us looking from the outside in, we see that you probably wouldn't have trouble with your boss or your wife or your neighbor or the policeman if you would put that bottle down. So they see the drug or the behavior as their solution, where most people are aware that the drug or the behavior is actually the cause of the problem. And they have a very dysfunctional emotional response. They do not like to hear the word no. When I work or train pain management doctors about the disease of addiction, they will all, you can just see their faces change as I describe the patient who walks into their office, into the lobby, and begins to inquire about the refill for their prescription that didn't get called in. And the office staff are just horrified at the fit this person might throw in order to do whatever they need to do to get the doctor to write the prescription and to reorder their OxyContin. They have a very dysfunctional emotional response to the word no. They don't like to hear it. They won't put up with it if they can at all possible have another choice. And because of this, it's very characteristic. You will recognize it. You'll see their name on your list of patients for the day, and you will have a visceral reaction to it. Like other chronic diseases, addiction often involves cycles of relapse and remission. We don't ever want people to relapse, for sure, but it is part of the natural process of this disease. Our hope is that people recognize it sooner and get out of it quicker, and that they recognize it doesn't mean they failed. It means that their disease needs some increased attention. We do as well treating the disease of addiction as we see with other chronic illnesses like diabetes or hypertension or asthma. There is relapse rates for these folks too. Sometimes it's related to the person not taking care of themselves or taking their medication, following up with their treatment plan, and sometimes it's related to an episode of stress, an illness, or an injury, something happening outside that person's control, but relapses are common, and we hope that remissions are more common. Without engagement in recovery activities, addiction is progressive. and can result in premature death or disability. The opioid crisis, I think, has gotten everyone's attention because of the really premature death. There's actually some thought that our decreased lifespan is actually related to the number of young people who are dying of opioid overdoses, and that has brought down our life expectancy here in the United States. So it is an important disease to recognize, it's an important disease to respect, and it's an important disease to treat. The good news is that it is very treatable and very manageable, and people can live happy and progressive lives. So certainly at our office, it's very important that we make the diagnosis. The storyline does not always tell us whether or not someone has the disease of addiction. And it takes a lot more probing than just hearing the immediate reason for them coming in for treatment. We can't ever make the assumption that everyone has the disease of addiction. We get a lot of referrals from state licensing boards for doctors, lawyers, airline pilots, therapists, pharmacists, nurses, etc. We get referrals because there has been some disruptive behavior, and because of that, we do a very elaborate and intensive evaluation on those folks, including collateral evaluations with people in their lives. But we don't ever assume that because someone thought they had the disease of addiction that they actually did. So we want to make sure that they have the diagnosis, because if they don't, if they have gotten into trouble misusing a drug, they don't need treatment. They might need some support with coping with their divorce or dealing with the death of a loved one, but they don't need formal addiction treatment. And so making the diagnosis critically important. We do a lot of laboratory testing. All of our patients get a QEEG, neurocognitive testing. We use drug testing, and we'll talk about that a little more in a minute, not as a way to kick somebody out of a program, but to help us understand if they're, number one, being compliant with the treatment plan, and number two, if we need to adjust that treatment plan. We do multiple assessments with our multidisciplinary team. We do 12-step facilitation, although we do understand many people don't care for 12 steps, so we look for other alternatives for ongoing support after discharge, like smart recovery, rational recovery, some of the other 12-step community-based mutual self-support. We do groups, we do individual therapies, and these are individualized treatment plans based on what we determine is their problem and their best course of treatment. Certainly, we've got to make sure if they have urgent medical problems or psychiatric problems that those are addressed immediately, and looking for other long-term or ongoing medical conditions, a comprehensive physical exam, which includes the laboratory testing, pregnancy testing, and making sure that people understand contraception and some of the risks of sexually transmitted diseases, which are very high in this population. Mental health and psychiatric assessments, and we need to look at what's been their history of drug use and what's their current history. As you know, and we're not going to go into detail here, but each particular type of drug or alcohol has a specific effect on the body, and we need to make sure that we're assessing those accurately. The big one that we assess is the pituitary gland. This is something that I learned about not because of addiction literature, but actually I spent a year working in an interventional pain practice because I wanted to help understand the role of pain, psychiatric disorders, and addiction. And through reading their literature, I learned about a neuroendocrine disorder that resulted from the direct suppression of the pituitary gland when people are using regular doses of opioids or benzodiazepines to treat their chronic pain conditions. Now, these are patients using pharmaceutical grade regular doses. I'm thinking, what about my patients who are using massive doses and often not even pharmaceutical grade substances? What must be the effect? Because of that, I did a pilot study with the University of Georgia, and we found that of the first 150 men who came into treatment, that actually only one of them had a normal testosterone for their age. Now, that was surprising to me, may not be surprising to you, but it does explain a lot of the symptoms that patients have. You'll see the hedonic system, which is the nucleus accumbens in the ventral tegmental area, sits right above the pituitary gland, and it does cause suppression of the pituitary gland. The other thing that can affect the effectiveness of the pituitary is head trauma. So those of you who don't work with a population of folks that have addiction, and probably most of you don't, you need to be thinking about these neuroendocrine disorders if your patient has had a significant head injury, and sometimes even without a significant head injury. If you are seeing things showing up on your brain map or the history of the patient that are consistent with head trauma, you might want to think about what are all of the things that the pituitary gland controls. Oxytocin, very important in my patient population. We don't have a available commercial test for oxytocin right now. They do have it available in some research centers. By process of elimination, I will sometimes prescribe oxytocin for my patients, and it is very helpful to them. We know that the pituitary has action on the kidneys and affects blood pressure and the production of red blood cells. We know that FSH and LH affect both the ovaries and the testes. This is a big one that we often see, suppression of the LH and FSH. The pituitary is just not monitoring the levels anymore of the normal hormones circulating in the system. And as those levels begin to drop, the pituitary doesn't respond and does not send out LH, FSH, TSH for the thyroid. It is not stimulating the adrenal glands correctly. And because of this, we see great impact on the hormonal system that is often under-recognized or not recognized at all. Even neurosurgeons and neurologists that are treating people for horrific head injuries or strokes do not look at the neuroendocrine system. And we see the gradual dysfunction of folks associated with the development of low levels of thyroid, low levels of reproductive hormones, and other kinds of problems. So always think about this as part of your differential diagnosis when you're looking at someone with chronic fatigue, when you're looking with someone with abnormal weight gain, difficulty with concentration, depression, anxiety. Lots of things can be happening because of a head injury or because of addiction related to the pituitary. So sometimes we are looking at blood work. Sometimes we look at saliva. There's a number of ways that we look at the hormonal system, and this is just an example of some of the tests that we get from Genova Diagnostics. There's a number of other companies that we use. Just important to think about if you're having patients with these kinds of symptoms. Also important to think about if you have patients who are actively using drugs or alcohol, even if they're using normal doses of medication for pain management. Think about neuroendocrine dysfunction. Sometimes we have to look more in depth at other kinds of things that may be causing metabolic problems. And we see some of these show up in theta waves and alpha waves elevation. So again, thinking about metabolic and vitamin deficiencies that may be creating some of the symptoms. We do drug testing. We do GCMS or LC-LCMS confirmation. We don't just do a yes, no, like you see in the upper corner where that individual's peeling off that label. We might do an instant read, but our drug tests are sent off so that we can know, are the levels of marijuana coming down? Are the levels of the benzodiazepines coming down? Because these can stay in the system for so long. Inconsistent results, like if you see 6-monoacetylmorphine, that is a confirmation that heroin has been used. If you see only morphine, no codeine, then that's suspect that this person may have been using heroin. If you see codeine or codeine and morphine, that person probably has not been using heroin. We do genetic testing on a number of our patients, not all of them. We do genetic testing if someone has had unusual side effects to their medications, they have difficulty tolerating medicines, or they seem to be metabolizing medicines quickly. So we will often get genetic testing, which is done by a mouth swab. We just get a little bit of the epithelium, the cells from the inside of their cheek, and send them off for a variety. And we'll look at a patient with genetic testing in a moment. So we get a QEEG, not going to spend a lot of time on that. You guys are the experts. We also do a neurocognitive testing online, or neurocognitive screening. I like this one from My Brain Solutions. It does help us in a number of ways identify when people are having cognitive difficulties. Many of our patients, because they're professionals, have good vocabularies and social skills. So sometimes it's hard to tell exactly how cognitively impaired they are. This is helpful. When things show up on this particular evaluation, there are brain games, and I'm using air quotes for those of you who can't see me, because many of my patients say these aren't games and they aren't very fun. But the idea being they are very specific for the types of dysfunction that the individual displays on the test. This, they have access to these brain games for about 4 months, and then they can retake the test, which allows us to see progress as well as allows them. And all of this is for a single price. It runs about $100, which I think is pretty reasonable. If things show up that look very suspicious, I will certainly send them for more formal neurocognitive testing. But this allows us to have a good measure of where they're at, and shows us progression as they go along. We've got to look at co-occurring psychiatric disorders. Suicide risk is very high in this population, particularly if there is co-occurring psychiatric disorders like pain or anxiety or depression. We ask them every single day. I tell them, I'm going to ask you every time I see you, every time you sign in and fill in your a checklist, we're going to ask you about suicidal and homicidal behavior and thoughts. It's really important because this is a very high-risk group. We also want to look at how are they having any psychiatric disorders as we start them on treatment. Again, many of the medications that might be prescribed by us or by other healthcare providers can actually cause depression and anxiety, and we have to be aware of that. So all of these things need to come together to make sure that we're addressing and identifying problems. Medication has been a big issue, and we know that there are a number of medications that are FDA approved for use for people with addiction. Most of these medications are still underused in most treatment centers who require the person to be totally abstinent, and they're not supportive of some of these medications. But the FDA has approved 3 medications for alcohol, 3 medications for opioids, and 7 medications for the treatment of nicotine addiction. There is also in the 2016 a report from the Surgeon General, Dr. Murthy, on addiction in America. He talks there specifically about electronic technologies, including neurofeedback, as does Nora Volkow, who is head of the National Institute of Drug Abuse. So more and more neurofeedback is being recognized and accepted as a treatment modality successful for helping folks with addiction. So I won't belabor this, but only 30% of treatment programs actually offer medication, and half of the patients in those treatment centers that would benefit receive them. And this is a very another story for another day, but it's unfortunate that with medication-assisted recovery, people do so much better, and yet there's still such a prejudice, like there is against neurofeedback, against using some of these medications for help. So we're going to look at a couple of case studies. The first one is Melinda. Now, she's an interesting young woman. She's 26 years old when she first came to see us. She had a history of OCD, attention deficit disorder, initial anorexia followed by a stint of bulimia when she was in college. She had multiple concussions, and she had a history of seizures related to drug use. So as you may know, cocaine can cause seizures, or amphetamines can cause seizures when people are intoxicated. Seizures can be caused by alcohol, benzodiazepine withdrawal, commonly overlooked, commonly misdiagnosed. Often these seizures are related to substance use or substance withdrawal. So if your patient gives you a history of seizures, make sure you've also talked to them about their use of drugs and alcohol. The history of addiction with opiates was severe. She also became addicted to cocaine, marijuana, and alcohol. Now, this is one of the few patients that I've actually had because she was an athlete, hence her concussions. She didn't use drugs and alcohol in high school or in college when she was being drug tested for participation in sports. But she went out with her boyfriend one night, had some alcohol, got intoxicated with alcohol, and she allowed her boyfriend to shoot her up with heroin. Her first use and exposure to an opioid was heroin. 20% of our population now, because of the ease and availability of heroin, 20% of people, heroin is their first drug, their opioid of use. It is not necessarily OxyContin or hydrocodone or other kinds of opioids. So this was one of those situations where her first drug of use was opioids. She ended up dropping out of school, losing her scholarships. She lived on the streets for a number of years. Her life was severely impacted by her use of heroin. On her neurocognitive report, her cognitive function was not too bad. This is a total of 4.5 out of 10, but her ability to recognize her feelings or self-regulate her feelings was significantly impaired. She had a 6-year history of IV heroin use. We started her on buprenorphine or Suboxone induction, and she was stabilized over 5 days. She was treated for 1 year with 2 milligrams twice daily, which is actually a low dose. She is a success story in that she was able to discontinue her use of Suboxone, graduate from college. She has a very well-respected job with a nationally known not-for-profit. She's married. She and her husband own their own home, and they're looking to get pregnant. She has done very well in her recovery. We always ask people if they're going to start on medication-assisted recovery, whether that's with a buprenorphine product or naltrexone, that they take it for at least 13 months so they can get through every birthday, holiday, anniversary, so forth. So this is what buprenorphine tablets or film look like, and you put it under your tongue, immediate absorption, and very helpful. So for her, one of the things that we wanted to point out was the situation with cortisol. I hope you can see my cursor. So in a normal sleep-wake pattern, which is in this first column, we see about 30 minutes before we wake up, cortisol levels rise very rapidly so that our heart rate, our blood pressure, and our body temperature increase so that we wake up. That should be the hardest and most stressful thing we do all day, believe it or not. So then we have breakfast, and we get a rise in cortisol because cortisol helps regulate our insulin and blood sugar levels. So when we eat, our blood sugar is going to increase, and with that, cortisol is going to send a message to our pancreas, get out the insulin trucks so that we can drive that glucose into our muscles, our organs, our tissues, and keep our blood sugar the same. As we go through the morning, cortisol levels drop. I think that's why sometimes people want a coffee break or a snack so that they can raise their cortisol and feel a little more energy. We get our next rise of cortisol about lunchtime. Afternoon cortisols, I have no idea how to interpret them, so I always have patients get them within 2 hours of their usual wake-up time without any food. Our last peak of cortisol should be with supper, and then as we get ready and go to bed, cortisol levels should drop to almost undetectable range. At this point, our blood pressure, our heart rate, our body temperature drops so that we're able to go to sleep. So that's why if you have a normal sleep-wake cycle and a normal cortisol cycle, even though you're wearing the same clothes you've had on all day, and even though you are certainly having the house the same temperature, you may want your furry blankets and your fuzzy slippers because your body temperature has dropped. When that happens, melatonin is signaled and our sleep hormone comes on board, so we have normal restful regenerative sleep, and growth hormone is exquisitely sensitive to this drop in cortisol. Growth hormone, as you may know, is very important when we're little so that we get stronger and bigger and taller. But as adults, we need growth hormone to do our normal repairs, keep us young looking, and help us if we have an injury or an illness. If cortisol doesn't drop, melatonin's not going to kick in, and growth hormone's not going to kick in. So we're going to have lots of health consequences if we don't have this drop in cortisol. This over here just shows you again pituitary gland, growth hormone, effects on the adrenal glands, and so forth. Very important that this feedback loop helps us. When people have been active using drugs and alcohol, no feedback loop and no stimulation of these other hormones by the pituitary gland. So in her case, she actually had lower than expected cortisol. Very hard for her to get up in the morning, very difficult for her to have energy throughout the day. She craved salty foods rather than sugar, which is unusual. Most people who are opioid addicted crave sugar in their early recovery. So she had a low level of cortisol. She was at 3.1. We would have expected her to be at 13. Her vitamin D level was very low. And my goal for people, the range is 30 to 100. I want people to be in the 60 to 80 range. This is the treatment for seasonal mood disorder. Get your vitamin D3 level in the 60 to 80 range. Last year, our flu shot was terrible. We missed the boat, unfortunately. But all of my patients that were in this range, none of them got the flu. Her DHEA, which is important, not just because it breaks down to testosterone. This is very important for desire to have sex for both men and women. It's also critically important for the speed at which we process information in our brain. Her DHE level was low. We expected an optimal range for her to be around 350. She was at 120. And her testosterone level was also low at 11.5. We expected her, yes, women have testosterone, very important for orgasm, for strong bones and muscles, for all of us, male or female, but it's also important for a sense of well-being and a sense of self-confidence. So she had some issues with her testosterone being low. Now, fortunately, when we have someone with low cortisol, we will have them use a supplement, and I hope I'm not stepping on anybody's toes. This is one I use. It has adaptogens that help regulate cortisol, ashwagandha, rhodiola, Siberian ginseng. It also has a small amount of adrenal actual adrenal gland to give her a very low dose of cortisol, help her get up in the morning. So even if she's going to hit the alarm, hit the snooze several times, she takes her adrenal first thing in the morning. This will actually help her get up and help her have normal energy. We had her take some vitamin D with K2. K2 helps make sure when the vitamin D picks up the calcium in your blood, it puts it in your bones and not in your coronary arteries or in your brain. For women to be able to regulate DHEA and testosterone, it's much easier than for men. If we increase DHEA, then we will increase testosterone. DHEA is over-the-counter. All of these are over-the-counter medications, although you shouldn't really be using them if you don't know what the levels are. And then a good multivitamin with iron and amino acid supplements to help her. This is her initial brain map. After 24 sessions, this is her follow-up. This is looking at her symptomatology and what improved and what didn't before and after. And this is, of course, looking at the comparison between her study that was done in May and the follow-up after 24 treatments in October. So she had good normalization, little reorganization, and found some very good improvement. These were the protocols that we used, and she did very well with that. I'm going to do one more quick case, then I'm going to give you some take-home message, and then we'll open it up to questions. So this case is interesting. This is an older woman, 55 years old, with a history of bipolar, rheumatoid arthritis. She had a lot of inflammation, chronic insomnia, PTSD, and anxiety. Her addiction was primarily to marijuana, followed by alcohol and nicotine. So because of the effects of marijuana on cognitive functioning, she was not doing well. And this is a well-educated professional woman. Fortunately, she had overlearned much of that which was required for her profession, so she was able to do a reasonable job at work, but try and get this woman to have to learn something new, and she's not going to be able to do it. So this is a comparison of her before and after, and those showed up opposite of what they did. This is her first one after 24 sessions. We used 19-channel Loretta neurofeedback, and she did show marked improvement. Again, before, after her symptoms improved. And this is a look at her brain and her level of improvement, as well as the protocol she used. So interestingly, she was on a boatload of medication, most of which I'm happy to say we were able to discontinue. We undiagnosed her. She did not have bipolar disorder. No one really thought to ask, are you using any drugs? No one drug tested her. No one questioned her about what was going on with her from her exogenous drug use. And so, as often happens, well-meaning psychiatrists, primary care doctors, pediatricians, other folks, in an attempt to explain the bizarre switches in sleep and appetite and energy level and mood, give people a diagnosis of bipolar. Very rare diagnosis, and yet often given to our patients with addiction. So I spend as much time undiagnosing as I do diagnosing. All of these medications were discontinued. She was able to discontinue her Lipitor, and she is on her biologics for her rheumatoid arthritis. So she shows an opposite effect. Let me get rid of this. I hope it's not showing up on yours. Her saliva cortisol, this is our ideal normal range for cortisol. This is a saliva cortisol as opposed to blood, which we saw before. She was just elevated with cortisol throughout her day. And so she was given a supplement called Adaptinol. Now, we did genetic testing on her for a variety of reasons. One of the things really important that's consistent with folks with addiction is problems with the dopamine receptors, and she had altered functioning. She also had a very specific COMT, which you know is the enzyme that breaks down serotonin, norepinephrine, and dopamine in the brain. High normals often seen in our high levels of COMT. So they're breaking down neurotransmitters very rapidly, increases their risk for having the disease of addiction. She had the very specific genotype Val150 MET. This is associated with pot use, and particularly those folks who have this malfunction are very likely to hallucinate and may even become permanently psychotic with the use of pot. So important to know. About, I think it's 10 to 15% of the population has this mutation, and it is pretty significant. She also had normal opiate receptor functioning, so opioids not really appealing to her. She was a poor metabolizer here, for benzodiazepines and alcohol, and she had both genes for MTHFR reduced, which means she needs methylated B12 and methylfolate in order for any antidepressant to work for her. So important genetic studies in her. I'm going to switch now and go to another, just a take-home message that I'd like you all to think about, regardless of whether what your discipline is, regardless of whether you can do lab studies or not. If you're trying to heal the brain, a good multivitamin with minerals is very helpful. Chewables are the best because they're much more bioavailable, so have them take a Fred or a Barney or Wilma in the morning, and that can be very helpful to them. Vitamins, the B vitamins, really important. I often tell patients, even if we haven't done the genetic testing, that it's important to look on the label for the vitamins and see the word methylcobalamin and methylfolate. That covers the 20 to 40% of the population who have European descent. They're a European descendant that have poor methylation. This just covers them and makes sure that they have the already activated form of B12 and B9. You can find it most of the time. It'll say in the ingredient section just cobalamin or cyanocobalamin or just folate or folic acid. Get the methyl word in there. They'll thank you for it. Helps so much with energy, neurotransmitter production, and with hormones. Also, magnesium. Magnesium is very helpful for anxiety, to help with sleep, to help with constipation, lots of things. You can get this over the counter. Tell them not to get oxide. That's unfortunately the most common kind, but it's one that we can't absorb very well as humans. The vitamin D3 with K2, around 4,000 to 5,000 IUs per day. Almost everybody is vitamin D deficient unless they're drinking 6 to 8 glasses of milk a day, or they're a nudist and they've given up bathing. So in Atlanta, at our latitude, you would have to be outside completely naked, covered in sweat, from high noon until 2 o'clock. For the sun to interact with the sweat on our body to make this important hormone, mislabeled as a vitamin, make vitamin D. Then the trick is that you can't bathe for 12 hours because that's how long it takes for your body to absorb the vitamin D. So even my patients who work outside, even my patients who have good tans, they do not have enough vitamin D. So really helpful. And then the omega-3 fish oils. Look on the back, the front of the bottle. Doesn't always tell you the truth. You need a combination of DHA, which is brain, EPA, which is cardiac. If you're just looking for normal health, around 1,000 milligrams. If you're looking to treat a severe depression, a traumatic head injury, other kinds of problems, you may want to go up to 4,000 units. I have people take this at night because it's at night that our brain is repairing, and it's also at night that we're making cholesterol. The other thing is I tell them to put it in the freezer because that helps the oil not become rancid, and it also keeps them from getting fish burps at taking this much of fish oil. So now I think, Dr. Suter, if we could use the last few minutes for any questions folks might have.
Yeah, I'll start unmuting people, and please remember to mute yourself if you don't have a question. And we're going down.
Susan, this is... Whoops.
Hey,
Susan, this is Rob. I came in late. If you're willing and able, if you will email me your handout, we'll get that out to people who attended tonight. You've got a great attendance, and that was a great presentation.
Thank you, and I'm happy to do that.
Okay, great.
Yeah, we're getting there.
And it was funny, while he's unmuting people, I had put out in our listserv the other day about people and the use of supplements because there was an article that said, you know, science goes back and forth, the supplements were useless, and then I had several folks who responded who work, you know, either as clinicians and some of them as physicians who said, well, if you get a good brand, then, you know, so if you have any recommendations for brands and you want to just pop those in, you know, somewhere along the way to us, that'll be great as well. I know pure encapsulations is popular. With many
correct.
folks.
That's a very good one. I use orthomolecular. I use Metagenic. I send my patients to places like Whole Foods or Fresh Market. They often have very knowledgeable people there who are paying attention to expiration dates, and they carry very good fish oil, for example, like Nordic Naturals. So that's a good source if people can't get access to some of the more restricted brands. That's a good place to go.
Yeah, and I saw that your brand was, I just looked it up real quickly while you were talking. It's available on Amazon.
It is. It's not supposed to be. Not supposed to be. And on the bottles it says not to be sold on Amazon. That being said, yes, you can get it, and
While
people
supplies
can.
last.
Yes, exactly. And you can come to my website at Atlanta Healing Center, and you can order online if you need something.
Perfect.
Happy to do that. And I know they work. The reason being that I actually do blood levels afterwards and make sure they're absorbing and that the levels are coming up, or I adjust the dose.
Thank you. Folks, anybody have some questions? We have a little bit of time left.
This is a quick one, but Dr. Susan Blank, I appreciate your saying that for 13 months the people need to take Suboxone or the other medications and going through the seasons. Just say briefly why that is. You're going through a whole 13 months.
Well, my thinking around that is that you need some distance from your active use, first of all. Hopefully during that time you will have changed your people, places, and things that are associated with your drug use, that you've learned some coping skills, that you've been engaged in therapy, that your depression, other things are stabilized, and that you've found a way to get through every holiday, every birthday, every anniversary of relapse, that you have learned to be able to deal with it and gotten through your first year anniversary, which is a high relapse time for people, believe it or not.
Mm-hmm.
I have a question.
Yeah, please.
Yeah, my question is for those that you work with who are successful with, incorporating all aspects of the program, compared with those who, start off and then they kind of drop out, do you know if there are differences just with those who start off receiving neurofeedback and then, they don't complete it, and then also those who maybe aren't open to some other aspects like the addition of vitamins, etc. Do you have any differences between those patients that show, different aspects of treatment that are really working better than others, or, that show that everything together is so much better, because it would be so wonderful to be able to provide everything, but so often I have difficulties with people being able to either afford it or maintain all of the additional aspects that you're describing. So
yes, that's a great question, and my answer is neurofeedback is the game changer. I have worked in many treatment settings and residential, outpatient, intensive outpatient, all kinds, very good centers. The difference between how quickly my patients regain cognitive abilities, their sleep is improved, their anxiety is decreased, their cravings are decreased. It's remarkable. It is completely night and day. I can't tell you enough how this has changed my practice. I have patients, they hate the gel in their hair, they don't want to come, mommy's making them, the medical board's making them, and they refuse to do the neurofeedback. They do not do as well, they don't stay engaged, and many of them relapse very quickly. So I'm not saying that people who do neurofeedback don't relapse, but I'll tell you what happens is they come back into treatment much more quickly, and we're able to turn them around much more quickly. It's a game changer. If I had to pick only one thing, it would be basic vitamins, neurofeedback, and go to AA. Those are the core things that are going to help people stay sober, in my opinion.
Thank you very much. That's helpful.
Dr. Blank,
Yes.
do you have any recommended areas that you begin with the neurofeedback? Do you get the areas that are going to decrease the dopamines, or where would you suggest we begin?
Well, that's a really good question, and Dr. Suter and I have had this discussion. We don't do protocol specifically like the Peniston protocol. We look at what does their brain bring to the table. So whatever pops up as the areas they need treated, that's where we go. because when we stabilize those things, then other things get better. So it really is individualized. We don't have a standard protocol. It's whatever the patient needs, that's what they get.
Okay.
Thank you.
Thank you.
And Dr. Suter's been very helpful in helping us figure all this out.
Well, and I have to say, one of the things I notice, because I see pre-post brain maps from clinics all around the country using all kinds of equipment and procedures and approaches, and Dr. Blank's clinic has been consistently the highest rate of change of any map grouping I've seen in clinics. And I know it's not the equipment, because it's other groups using her equipment aren't getting that, but you can see it's the total treatment regime and the way that she utilizes nutritional products and so strategically, and also medication strategically. It's pretty impressive, the outcomes on a consistent basis, and that's why I think it's important that people pay attention to what she's doing and how she's approaching it.
Thank you.
Along the lines of the patient that had DRD dysfunction, are you do you endorse the work of Kenneth Blum on reward deficiency syndrome, and you use that approach in your treating people with addictions?
Thank you. That, again, very good point that we didn't get to go into, but absolutely. My go-to antidepressant, if I write one, and really I'm a fellow of the American Psychiatric Association, but they'd vote me off the island if they knew how rarely I write psychiatric meds. But if I need one, it is Wellbutrin. When I describe to patients what that feels like, to be the kid that sits in the back of the room in second grade when the class is going nuts because the teacher just brought in a hamster, and they're all so excited, and can we name him, and can we touch him, and can we hold him, and can I take him home? And they're the kid that's saying, it's a hamster, people. They really do not have sufficient, not all of them, but many of them don't have sufficient dopamine to find pleasure in just the normal everyday life. And so they must do adrenaline-seeking activities or the use of drugs to even feel normal. And they will often say, the first time I felt normal, not high, not buzzed, the first time I feel normal was when I used.
I think we got it.
Okay.
There we go.
Besides Wellbutrin, are there supplements that you recommend when people have dopamine deficiency?
There are a couple of supplements that have a precursor for dopamine in them. That are available from orthomolecular in particular, and also from Metagenics. They do have an L-DOPA precursor. Have to be careful with them, but those are very helpful in small doses for people to just feel better and to begin to get some dopamine. Staying off drugs that are releasing the dopamine, also very helpful, but can be, really helpful for them to have that. But none of the other antidepressants work on dopamine. It's the only one.
One last question. There is Kenneth Blum has a company, I think, called Synaptogenics.
Yes.
It's a combination of phenylalanine and N-acetylcysteine and a whole range of things.
Tyrosine.
That's something you use or you're familiar with?
Yes. Oh, yeah. They're all very good. And when we use them, we use N-acetylcysteine and time-release niacin for helping with cravings. The tyrosine, phenylalanine, all of those things can be very helpful for normalizing neurotransmitters and particularly dopamine.
Dr. Blank, you established that there's that sugar is one of about 30 substances that stimulate reward structures in the brain to release dopamine. I thought that was interesting. What do you say to people who researchers I've heard mention that sugar is unlike other heart addictions because it doesn't provide the withdrawal symptoms that normal hard drugs do, and that if people do override their satiation for food by consuming sugar, it would be an indication of maybe a disordered eating behavior, which would be secondary to something else, and maybe not such a hard addiction. What would you say about that?
Well, evolutionarily, that is the only substance that we are hardwired to seek. So when we used to have to chase down the antelope, it was really important that we noticed honeycombs and ripe fruit and other things. So we're wired to look for sugar. And it was fine when sugar was, hard to get. And we were running, chasing down the antelope. Now that sugar is in pretty much everything, and we see the epidemic of obesity in this country, and children under the age of 12 with type 2 diabetes, which is supposed to be adult onset related to weight gain. When we see kids being diagnosed with that, yes, there may not be a withdrawal syndrome, although ask most people that go on a diet and avoid sugar if they don't have some withdrawal and don't have some cravings and don't have a desire to use. But yes, sugar is an epidemic, and while it may not cause you to overdose necessarily, it may very well be affecting your health, your mood, your mobility, and mortality. So it releases dopamine in the same region of the brain that does cocaine, does methamphetamine. The amounts are different. Not every substance has a withdrawal. Inhalants don't have a withdrawal. There's not a formal withdrawal associated with amphetamines. Not every substance has tolerance. So the 11, which is part of my problem with the DSM-5, is the 11 criteria. They've tried to make everything fit everything, and not every substance even has the opportunity for some of those criteria. But I do think that sugar is a huge problem, and we do ask our patients to try and decrease sugar, caffeine, and nicotine. At the same time, they're stopping everything else. So they really hate me most of the time, but that's okay.
Thank you.
Okay.
You're welcome.
Those were all excellent questions. We're getting pretty far past the hour, and I'm sure Dr. Blank would like to go home and have dinner or at least go to bed, and we all should as well get our 8 hours. So
Correct.
We'll wrap this up. Thank you for the wonderful questions. They were great. Susan, Dr. Blank, thank you so much for another excellent presentation. I know everybody got a lot out of it, and we'll be posting it up on the New Mind YouTube channel. And you can see we've got an excellent clinic here in Atlanta if you need for addictions, and a website where you can get these really high-quality products, which she uses herself effectively. So I think some good tips. You might need help with the testing, but all good things to know for us all. Anything to add, Rob?
No, just a big hearty thank you so much again, Susan. Great presentation, and we'll get your hand out when you get a moment out to people. So thanks so much again for being with us, and have a nice evening, and everybody, we'll see you Wednesday.
See you Wednesday.
Thank you all. Good night.
Good night.
Bye-bye.